In our last lesson, we will continue our discussion on cardiopulmonary monitoring, focusing on invasive monitoring, which will include arterial lines, central lines, pulmonary artery catheters, and intracranial pressure monitoring. As a monitoring tool, arterial lines are one of the most common for the respiratory therapist to use, as it provides access for ABGs. For patients with hemodynamic compromise, a low stroke volume, and peripheral vasoconstriction, which may make carotid cough sounds impossible to hear and arterial pulse difficult to detect, this may be the only way to assess systemic blood pressure. Access is usually achieved by inserting a catheter, most commonly in the radial artery, although the femoral, and less commonly the brachial, axillary, ulnar, or dorsalis pedis arteries may also be access points. Monitoring requires a pressure transducer, pressure transmission connective tubing, and a pressure monitor or recorder. The transducer is a piezoelectric crystal that creates a change in voltage when pressure is applied to it. This voltage is then amplified and converted into a graphic and numeric image on a monitor. The monitor then displays systolic, diastolic, and mean arterial pressure as we previously discussed. This MAP does not vary much with motion artifact or movement of the catheter site and is a reliable clinical tool since it relates to cardiac output and systemic vascular resistance. Transducers for arterial lines should be placed at the level of the heart, more specifically at the level of the right atrium, to assure accurate blood pressure results. Precautions while placing the transducer on the IV pole are to watch for a transducer placed too low, as it will result in a blood pressure reading higher than it should, and if placed too high, a blood pressure lower than the accurate numbers. Central lines are used to measure central venous pressure, CVP, or right atrial pressure, which tells us about cardiac function and intravascular fluid status. Increases in CVP may indicate fluid overload, right ventricular failure, tricuspid insufficiency, or chronic left ventricular failure. Low CVP may indicate hypovolemia and dehydration. The catheter is placed by a physician in either the subclavian or jugular vein, sometimes the femoral vein, and is advanced into the proximal superior vena cava. It can then be used not only for cardiac measurements, but also for administration of medications and fluids, blood sampling, or emergency placement of a pacemaker. If a CVP line is required for longer periods of time, a peripherally inserted central catheter or PICC line or a tunnel catheter will be used for intravenous access. Risks associated with CVP lines include those that occur during insertion, such as pneumothorax. The line should always be checked with a chest X-ray after insertion, bleeding, arrhythmias, and entry into the nearby arteries. These risks have been greatly reduced with the use of ultrasound to guide the catheter advancement. Risks after the lines are in place are infection, catheter dislodgement, occlusion or breakage, and very dangerously, induction of air into the venous system, resulting in a potentially life-threatening air emboli. Pulmonary artery catheters, sometimes called Swan-Ganz catheters, are used to directly measure right atrial pressure and pulmonary arterial pressure, and indirectly measure left atrial pressure. They also can be used to determine mixed venous oxygen, SVO2, and cardiac output. The catheter is inserted by a physician and introduced via a central access point, such as the internal jugular or subclavian vein, and is then passed from the vena cava into the right atrium, through the pulmonary valve, and into the pulmonary artery. There are two ports connected to the pressure transducer. The distal port measures the pulmonary artery pressure, and the proximal port measures the right atrial pressure. The left atrial pressure can be measured by inflating a balloon at the tip of the pulmonary catheter and essentially wedging the catheter into a branch of the pulmonary artery, effectively occluding it for a couple of seconds. When this occurs, the pressure in the distal port falls rapidly and reaches a stable value after those few seconds that is similar to left atrial pressure, which when normal is approximately 8 to 12 millimeters of mercury. Reasons to measure this pulmonary capillary wedge pressure include to assess the severity of left ventricular failure, mitral and aortic valve dysfunction, to assess and treat pulmonary edema and hypovolemic states, and to evaluate pulmonary hypertension. Cardiac output can also be measured by injecting a cold bolus of saline into the right atrium, thermodilution technique, and looking at the resultant temperature change with a thermistor sensor at the tip of the catheter. Although cardiac output measurements are helpful, they do not account for a patient's specific cardiac output needs with respect to body size. The calculation of cardiac index takes care of that issue and is determined by dividing cardiac output by the patient's body surface area. The normal range is between 2.5 to 4 liters per minute per meter squared. A cardiac index of less than 2.2 liters per minute per meter squared indicates cardiogenic shock. Mixed venous oxygen saturation, SVO2, is also measured with a pulmonary arterial catheter and reflects the amount of the oxygen left combined with hemoglobin after the tissues have extracted the oxygen needed. Normal values for SVO2 are between 60 to 80%. A decreased SVO2 indicates either increased oxygen demand by the tissues or inadequate cardiac output to meet those demands. Possible complications of a pulmonary artery catheter usually relate to the insertion of the catheter, which can cause malignant arrhythmias, pulmonary artery rupture, or pulmonary valve tear or wall in the body, and increased risk of infection. Our last topic will be intracranial pressure monitoring and its use in assessing low cerebral perfusion pressures. We will also briefly discuss other diagnostic tests we may see with a brain-injured patient. The causes of brain injury include trauma, hypoxic and anoxic injury, aneurysms, hemorrhages, cerebral tumors, or brain surgery. Generally, tests for brain injury fall into two categories. 1. Tests that examine the structure of the brain and include MRIs, CT scans, and MRAs, magnetic resonance angiograms. And 2. Tests that look at the function of the brain, such as EEGs, single photon emission computed tomography, or SPECT scans, or positron emission tomography, PET scans. CT scans are often done frequently after the injury to assess how much tissue is involved. MRIs are better at detecting injury due to the better resolution and are better at detecting remnants of old blood or damaged but intact nerve tissue. MRAs look at blood vessels and possible bleeding of these vessels. EEGs use tiny electrical signals coming from the brain via electrodes placed on the scalp. Slowing of activity in one area may indicate brain lesions, and widespread slowing may indicate brain damage over a wider area. PET scans can detect areas of the brain that are not using enough glucose, and when combined with MRIs, can show both functional and structural defects in the brain. SPECT scans are similar to PET scans in that they can be used to see the brain's blood supply, but are cheaper and more available than PET scans. And lastly, intracranial pressure monitoring may give the clinician a warning of brain swelling that often occurs after traumatic brain injury. The normal range for intracranial pressure, or ICP, is 0 to 10 millimeters of mercury for adults and 0 to 5 millimeters of mercury for patients younger than 6 years. ICPs may increase transiently due to coughing, Valsalva maneuvers, prone positioning, head position below 15 degrees, and pain. Therefore, special care must be observed when monitoring these patients. It has been a pleasure having you in Cardiopulmonary Diagnostics. We have learned about various tests that not only diagnose but continue to monitor patients in the acute and non-acute settings. We have also looked at various diseases of interest to the respiratory therapist and various diagnostic findings to help us better evaluate and treat our patients. I hope you have enjoyed this class as much as I have enjoyed having you as students. I'll look forward to seeing you in future classes.